We just heard from Dr. Wallenstein that efforts are being made by universities to involve the community in what's called community-based participatory research. Community and academic partnership for research is a great way to do research. We all know that. Sometimes universities don't. CMAR obviously supports this kind of research. The question then becomes, how do we get the community involved in partnering up with universities and colleges? One quick solution is get your nonprofits in your community involved. In Seattle-King County, there's a lot of them. We have El Centro de la Raza, Consejo, Casa Latina, Northwest Immigration Rights, and many, many more. In Eastern Washington, we have many other sister organizations that are more than willing to be partners with colleges and universities. Another group of partners for universities is community health centers, like CMAR Community Health Center. Community health centers are community-based organizations, that serve low-income patients in accordance to their ability to pay. We are located in high needs area. We work and are open to all residents, whether they're low income or whether they can pay. We provide services in a culturally appropriate way. We are very comprehensive in nature. We provide primary care, but a lot of other related health services. And our focus is on health prevention, and our costs are really low in comparison to private practice. I wanted to give you a little bit or a little statistics on national community health centers in this country. There are 1,128 health centers around the country. We have about 8,500 delivery sites throughout the country. We serve 20 million people and provide over 80 million visits to this population. We serve about 800,000 farm workers and serve about 1 million homeless individuals. Health centers provide services to 1 in 7 Medicaid beneficiaries, 1 in 7 of all uninsured persons, 1 in 3 of all individuals below poverty, federal poverty levels, and 1 in 7 of all rural America. In Washington State, there are 26 community health centers. We have 180 delivery sites. We serve almost 800,000 people, and we provide over 3 million visits to this group. CMAR Community Health Center is one of the 26. It was started by a group of health science students from the University of Washington in April 1978. I became the executive director of the organization in June of that same year. We started with a staff of less than 10 people and have grown to a staff of about 1,700 individuals. We're located in 11 counties, from Clark County and Vancouver all the way to Whatcom County in Linden, Everson, Washington. The services that we provide, are really very, very comprehensive. We have medical, dental, mental health, substance abuse, maternity support, WIC. We have a 100-bed nursing facility, 120-bed assisted living facility. We have a child care center. We provide home health services and many, many other services. We're probably one of the most comprehensive health centers in the country. Last year, we saw about 240,000 patients. We provided over 900,000 visits to this group of patients. 41% of our patients are Caucasian, 40% are Latinos, 6% are Asian Pacific Islanders, and the rest are other minorities. CMAR has been involved in research since the very beginning, even though in the beginning we were really reluctant. We were reluctant because lots of times, we were approached by researchers from the University of Washington or other colleges, and they were really not ready to work with the community. But slowly we begin to develop relationships with them. One of our major concerns, obviously, was that we wanted to make sure that any research that was done protected our patients. The traditional way of doing research really did not have the proper protection. So I'm glad to hear that there is a model that's going to be working or should be working now in universities, but I think as people learn about the model, I think institutions like the University of Washington will be using that type of methodology for research. Now, in terms of our current research application, we have a fairly straightforward, probably traditional methodology. We require the researchers to describe the goals of the research project. It must be clear. The methods of data collection needs to be fully described in the application. The significance of the research and how it will help our community needs to be fully described in the application. We want to know what the impact on our clinical operations is going to be. Lots of times our staff is busy with work that they're doing every day. Research sometimes interferes with that process, and so we want a clear description of what it's going to take from our organization to do the research. And obviously we're concerned about cost and sources of funding. Research that uses human subject must be properly planned to ensure that our patients are fully protected. Participation must be strictly voluntary by our patients, and the researcher has to fully disclose all the benefits and the cost to our patients. When research involves human subjects, the CBPR policy requires additional safeguards. Each participant must be well informed. A written consent form must be completed and signed. The research must specify the criteria for selection or exclusion of patients and describe the method and procedure to be employed. The researcher also must describe how patients will be informed of what their objectives and procedures are. And finally, the patient must have the ability to withdraw at any time during the research. We have a process that we follow. We have a research committee in our organization. The proposal first goes to a committee of the staff. The research committee assures that our policies are being addressed and reviewed, and reviews the application in full detail. If the committee approves the application, it's then presented to the management team. The management team, our management team is kind of huge. We have somewhere in the neighborhood of 40 to 50 individuals, and we meet every other month. And believe it or not, we take this process very, very seriously. We ask usually the researcher to come and make a presentation to this group. And we ask a lot of questions. We really want to make sure that our patients are fully protected. If this committee approves the application and then goes to the board of directors, and then the board of directors have the final say as to whether the project will proceed or not. We encourage publications for the benefit of our patients, and we like for the researchers to give credit to our organization if credit is deserving, and it usually is because we're part of it. Over the years, we've been really successful in partnering up with partners, including the University of Washington. Here are some examples of the research that we've done in the past. Cancer screening at an FQHC, a qualitative study on organizational challenges in the era of the patient-centered medical home. Our partner was University of Washington. We had principals Martinez, Gutierrez, Angulo, Jimenez, Coronado, and some other ones, and this was done in 2013. With Children's Hospital, we did a search for diabetes in youth. This was done by one of our staff members, Sarah Barker, in 2011. Screening mammography in Latinas, a multi-level intervention. We did it with Fred Hutchinson Cancer Research, and one of the principals was our medical director, Dr. Jimenez. So you can see that we do have experience in doing research, and our research has really been very well received by our staff and by our community. In addition to research, we have relationships with many colleges and universities for training. One of the really important relationships that we developed early on with then Providence Hospital, now it's Swedish, we developed a family residency program. At the time, this was in 1987, at the time, a lot of residency programs that were affiliated with the universities basically had their own residency program, and then they had community clinics that would accept, some of the residents to do some outpatient work. We were finding that a lot of the doctors that we were hiring that were coming from inner city family residency programs were coming to us, and then they were staying with us for 2 to 3 years, sort of fulfilling their commitment that they made to the medical school, and then they would leave. And so we had a fairly high turnover rate in terms of family doctors. And so we came up with the idea that, we need to train and introduce family doctors early on in their career into community medicine. And so we went to Dick Layden at Providence Hospital, and we said, we want to start a residency program that is community-based, that is actually out of our health center. And the reason that we want to do that is we're hoping that if we introduce these young medical students that are becoming residents into community medicine, that they will stay in community medicine. We have been extremely successful as a result of that. We were probably the first community health center to have its own residency program. The residents were doing their outpatient care at our center and their inpatient care at the hospital. But we decided, who we're going to match with. And so we interviewed the residents. It was our faculty, our staff, and the residents that work in the program that makes the final decision instead of the residency program. So it's been very well received. Dr. Maestas, who is a professor at the University of Washington, did a study a few years ago, and her conclusion was that 95% of the graduates, the CMAR graduates, are either working in a community health center, or they're teaching at a university, or a university-related program, like residency directors or so forth. Another training program that we started with South Seattle Community College that we're really proud of. We went to South Seattle Community College and asked them to start a CNA program for monolingual Spanish-speaking individuals. At first they thought we were crazy, but after we spoke with them and they realized, that there was a need for bilingual bicultural CNAs, that they knew enough English that they could pass the exam. And so after working with them, we started a class of 25 individuals. 24 of those 25 passed the exam for CNA, and the exam was done in English. And so if colleges or universities are willing to work with community-based organizations, we know how it can be done. And if you can get a group of monolingual Spanish-speaking individuals to get licensed in an English-speaking CNA exam, I think it says a lot to what community-based organizations can do. We have a formal agreement with about 50 educational institutions. We provide intern and extern learning opportunities in our organization. They range from Bellevue College to Edmonds Community College, Gonzaga University, North Seattle College, Skagit Community College, University of Louisville, University of Washington, University of Wisconsin. And so we have many internship programs and training. And we view that as very, very important because sometimes a lot of these training programs really are not exposed, to community medicine. And by having these internships, we get them exposed to our type of organization and get them interested in working in community-based organizations. What are some of the barriers to research? From our point of view, there are challenges in the area of our IRB, or the Institutional Review Board. The university has a set of policies. We have another set. Sometimes it's very time-consuming to go through the process, and so perhaps we can streamline that process. At times, some of the material that we get from the university, even though it's been translated, it hasn't been done correctly. Sometimes the university doesn't have the capacity to translate in other languages. We have patients that speak Asian languages, and they just don't have the capacity. And so I think the university could do a little bit better job in that area. At our health center, we don't really have a well-structured, well-staffed research department. We do research. Sometimes it is a difficult thing to do without resources. Our staff take on that responsibility. It's an added responsibility. It takes additional work and additional time. Sometimes there's a lack of funding. The university gets their cut. Community-based organizations rarely receive theirs. We're beginning to see a change there. Fred Hudson, University of Washington, are beginning to be more sensitive, and they at times do share some of the money that they get from their grants. Communications, I think that's very critical. Lots of times when projects start, there is good communication, but once the project is underway, the communication ceases. And so I think we can do a better job there. As far as priorities, for us, we do have needs. Like many other nonprofit organizations, we've identified 3. We would like someone to look at the management of chronic disease regarding patient behavior, such as the motivation and adherence to treatment. This suggestion came via Dr. Jimenez, who is our medical director. Actually, all 3 of them did. He would like to see an effective model for integration of behavioral health and primary care. There's lots of discussion in the paper about behavioral health and some of the problems in this state with behavioral health. Why isn't the University of Washington leading the effort, to find a solution? Why are they not working with community-based organizations to find the proper model that will work? Another thing that we need is a model of postgraduate training in community-based centers for health care disciplines, such as medicine, and I'm talking about residency programs, dentistry. Once again, a residency for dentistry. I know that Yakima started a program there not that long ago. More are needed. Behavioral health, pharmacy, you name it. Every health discipline needs additional ways of training individuals. The baby boomers are going to be retiring soon. A lot of us that are in our 60s and getting near 65, well, we'll be retiring. What's going to happen to the community if the universities are not producing enough individuals to replace them? And so that is, I think, one of the most needed study that needs to be done by researchers. How can we efficiently train more health professionals? Elements of a good partnering from our side of you, and I really appreciated what you told us this morning. Transparency, it's really important. We need to operate in the open. Sometimes universities have hidden agendas. They don't let us know what they are. I think that does not do any good, for good communications. There must be trust and respect. The goals need to be clear for all participants. Lots of times we really don't communicate. We think the university is doing some type of research, and we end up finding out that it was a little different. So early on, it's really important that everything is really, really clear. I mentioned financial support for community-based organization. More funding needs to be made available. Whenever research whenever grants are submitted to the federal government from universities, some provision need to be made to get some funding to the community-based organizations. Human subject protection, I think, is really important. I think we do a good job in that area, but sometimes we can do better. Credit for failures or successes of the research needs to be shared with the community-based organization. We don't mind at times failing, but we hope that it never does. But even if it means, that the research didn't work, we think that community-based organizations, should be involved in getting the credit or the failing of the research. In terms of a structure that is needed, in our opinion, for a good academic / community partnership, we value partnerships that are equal, just like we did with Providence and we have with Swedish now. We view ourselves as equal partners. They're not any better than we are, and we negotiate and we communicate, when there are issues. The sharing of financial resources is important. I mentioned that already. We need a structure that develops community capacity building. I think that's really critical. Universities lots of times don't want to spend energy in doing that. That needs to happen. How are nonprofits they don't have experience with doing research going to learn if no one teaches them? Transparency is important. Lots of times, we talk about transparency. We say that we're going to be transparent, but how do you really accomplish that? How do we really know that people are being transparent? How can you develop that trust if that is not defined? And so I think that we need to work on that. The structure for good communication must be present as well. Overall, what I heard this morning by you, Dr. Wallenstein, I think it's a great model. It's a model that I think makes a lot of common sense. I'm not really sure why the universities have not been using it all along. We fully support that. We're very excited about this institute. We want to work with the university to make sure that it is successful. Thank you very much. I would be very happy to answer any questions that you may have.